So as far as definitions and phenotypes, so this is going to be important for our overall understanding of the condition. We're talking about a complex condition that has various levels of action. It's defined primarily as an endocrine disorder, and it is the most common endocrine disorder in women of reproductive age. You can see these varying levels here in relation to, say, for example, up top, the hypothalamus and the pituitary. And there are disruptions to this level that influence what goes on downstream. We've got the pancreas as the site of production and release of insulin. And insulin is intimately related to the overall profile of sex steroid hormones, so specifically androgens in women with PCOS. There's also a role for the adrenals, although it's less well understood. The adrenals in female physiology are an important secondary site of androgen production, second to the ovaries. And there is evidence of women with PCOS exhibiting an excess of adrenal androgen production. But again, it's not nearly as primary as ovarian androgen excess production. So the adrenals do appear to be involved in some way, but the evidence isn't really as concrete for what we would have as an understanding of the elements of ovarian androgen production and the relationship between insulin and androgen production. And we'll go through this schematic is the kind of easy version in a little more detail, so we get an understanding step by step of what's going on, because the pituitary, which produces follicle stimulating hormone and luteinizing hormone, is a huge part of this overall pathophysiology, and may be relevant for how we think about some of the dietary interventions. So overall, we can say that it's characterized by hypothalamic, pituitary, adrenal, although less so than the ovaries, ovarian axis dysfunction and its dysfunction. And it may be primary site of dysfunction, so to speak, may differ depending on the specific phenotypes and different presentations of PCOS. Despite this understanding of the axis of dysfunction, so to speak, the actual origins, the precise etiology of PCOS remains relatively unknown and still the matter of further investigation and research. So let's take this a little further and elaborate it out. And I know you're probably looking at this thinking, what in God's name are all these arrows and illustrations? We're going to work through this sequentially. What you can see at the top is the level of the hypothalamus. And primarily what we're looking at here is gonadotropin releasing hormone, GnRH. And then we've got the next level down, relevant, the anterior pituitary hormones, and that's follicle stimulating hormone, or FSH, and luteinizing hormone, LH. And they feed then downstream to the endocrine targets, the ovaries and the pancreas with insulin. And then we've got this relationship between insulin production and androgens. And we've got this relationship between elevated luteinizing hormone, represented by this arrow here, and ovarian androgen excess. All of this combining to influence reproductive and ovulatory dysfunction. There is some role potentially for leptin, which is a hormone that regulates energy balance and central regulation of energy balance. And this may relate to adipose tissue function. But I've illustrated with the dashed arrow that these are really hypotheses at this point. And again, we don't have very concrete evidence for what precisely leptin may be doing in relation to PCOS. So I'm not going to focus on that today. Very much our focus is going to relate to this relationship between luteinizing hormone, ovarian androgen production, which you can see here with this arrow, and then, of course, insulin and the influence of insulin on ovarian androgen production. And particularly because in relation to insulin, this is something that we can think about when we're really looking at dietary potentials, potential for dietary interventions to benefit. So let's work our way through this sequentially. We'll start at the very top, the hypothalamic hormones. What we typically see in PCOS is gonadotropic disruption, or increased levels of this hormone GnRH. There's also evidence that where in non-PCOS, otherwise healthy women, for example, where they have got normal progesterone fluctuations over the course of their menstrual cycle, that progesterone can act to inhibit the stimulating effects of GnRH on luteinizing hormone production. And that's a positive thing because, again, it helps maintain the overall balance in the ovulatory cycle of these various hormones and the timings of their respective fluctuations. But in women with PCOS, there's evidence that there's resistance to that. In the first instance, they're not simply producing enough progesterone to characterize ovulatory cycles. And then, of course, that's allowing GnRH to continue pulsatile stimulation of luteinizing hormone. And that brings us to this next level then, represented by this pointed arrow up, which indicates that really this increase in GnRH, its primary role in PCOS is stimulating an increase in luteinizing hormone. Now, with follicle stimulating hormone, it's not necessarily that it's decreased. There's evidence that levels might be in otherwise normal ranges, but the fact that LH increases so much alters the ratio between these two hormones. And this high luteinizing hormone to follicle stimulating hormone ratio is observed in PCOS generally, and particularly might be important in the lean PCOS phenotype, insofar as it may explain how, without necessarily having some of the insulin resistance that the other phenotypes do, there can still be adverse effects on, for example, elevated androgens and potentially issues related to anovulation or oligoanovulation, like disruption to ovulatory cycles. And then we get down to these next levels then, which are actually crucial and endocrine target. I mean, the ovary is likely to be the primary site of some of the dysfunction, although the downstream concept helps us really put a picture together mentally of the relationship between all of these complex factors. What elevated luteinizing hormone serves to do is stimulate ovarian androgen synthesis. But the problem with the fact that we now have an imbalance of luteinizing hormone to follicle stimulating hormone means that one of the primary functions of FSH is to stimulate the synthesis of an enzyme known as aromatase. Aromatase is important because it facilitates the conversion of androgens that are produced in the ovaries into estrogens. And this is something that would occur, again, in the normal context of functioning or regular ovulatory cycles. In the context of PCOS, the imbalance of LH to FSH means that there's resistance of the follicles to the action of FSH. And therefore, that role of converting androgens to estrogens is inhibited. And this contributes to the ovarian androgen excess that is observed. And then we've got this really crucial role for insulin, which drives ovarian androgen production and indeed potentiates the effects of luteinizing hormone. And I'll elaborate on that in another graph so we can really kind of understand both the direct effect of insulin and the indirect effect of insulin in driving androgen profiles in women with PCOS. And then finally, this role for leptin, it's very less well understood compared to our understanding of, for example, LH or of insulin. It's a suggested role potentially interacting with adipose tissue, and there's evidence of adipose tissue dysfunction. But because it's still speculative, I'm not going to really have much of a focus on leptin for today's purposes. So how do we define or diagnose PCOS? The first criteria was the National Institutes of Health in 1990, and they required that 2 out of 2 characteristics were present. One was clinical or biochemical hyperandrogenism. What clinical hyperandrogenism typically means is it's not looking at an actual blood marker of testosterone. The most common used clinical marker of hyperandrogenism in PCOS is hirsutism, or male pattern hair growth on the female body. Biochemical hyperandrogenism would then be an actual specific blood based sample of for example, free testosterone, total testosterone, sex hormone binding globulin. So that's what's meant by clinical or biochemical hyperandrogenism. And then the presence of oligo or anovulation. So this is typically characterized in relation to PCOS in terms of oligoanovulation as less than 8 menstrual cycles in a 12-month period, or cycle lengths that are in excess of 35 days. And for anovulation, this is typically defined as no menstrual cycle within a 6-month period. This elaborated then in 2003 with a combined task force of both the European Endocrine Society and the American counterparts in what was colloquially termed the Rotterdam criteria. And this expanded the criteria to obviously specifically include polycystic ovarian morphology, so the presence of cysts identified on an ultrasound. But for a diagnosis, 2 of these 3 was required. And this was reflecting the fact that there are very different presentations of phenotypes with PCOS. And some individuals, for example, might have elevated androgens and oligoanovulation, but not necessarily polycystic ovarian morphology. So the question then is, do they not have PCOS because of the lack of PCOM? And so the Rotterdam criteria was trying to expand how we could capture the various presentations of PCOS. And then in 2006, there was an attempt by another endocrine and PCOS society to define the diagnostic criteria. And again, this really came back to 2 out of 2 of clinical biochemical hyperandrogenism, oligoanovulation, or PCOM, polycystic ovarian morphology, or both. So somewhat more related to the 1990 National Institutes of Health criteria. And then finally, there's a degree of consensus reached in 2012, again with the NIH. And so for the actual diagnostic criteria, this affirmed the 2003 Rotterdam criteria as the presence of 2 out of 3 of these factors, but also then made specific reference to characterizing these phenotypes. So what are these phenotypes? There's typically 4 that are currently recognized. 3 we could broadly define as hyperandrogenic, as in they all have the commonality of elevated androgens. And then phenotype D could be considered non-hyperandrogenic. This has other characteristics, but it doesn't have or exhibit elevated androgens in the diagnostic criteria. So phenotype A, this is often known as classic PCOS. So this is women with elevated androgens, with oligo or anovulation, and with polycystic ovarian morphology. Phenotype B is the androgens and the menstrual cycle disruption, but without the polycystic ovarian morphology. And then phenotype C is the hyperandrogenism and the polycystic ovarian morphology, but without ovulatory disruption. Phenotype D then is obviously non-hyperandrogenic, so it is oligo or anovulation in addition to polycystic ovarian morphology. There are open questions over to what degree do we consider, for example, from a dietary intervention perspective, do we consider more specific differences in these phenotypes? And we're really not at that level of evidence yet in terms of being able to make very targeted kind of, this is what phenotype B should do, or this is what phenotype D should do. And really there are unifying characteristics that we would want to target. So with the hyperandrogenic phenotypes, a reduction in, for example, androgens, and potentially mediated via reduced insulin levels or improved glycemic control, would be something that you would likely want to achieve across all of these phenotypes. So in terms of overall prevalence, the reason the diagnostic criteria was quite important is because it's potentially missing individuals in the population that genuinely have PCOS. The NIH criteria, only using that criteria, suggested that the average prevalence in the population was 6% and a range of 5 to 8%. But actually using the Rotterdam criteria, this changed. This was suddenly an average of 10% and a range of 8 to 13%. And if you look at some of the percentage, these are all percentages here in individual studies. It really depends on the study you're looking at. You know, some individual studies, for example, on average in the study population, 20% up to 24%, for example, or here 12%, 10 to 14%. So likely population differences. These are averages, but clearly the Rotterdam criteria is a more encompassing diagnostic criteria to capture the prevalence of PCOS in the general population. Okay, so we've got a rough idea of this process, this hypothalamic, pituitary, endocrine, and ovarian androgen, and indeed insulin-related dysfunction, and the characteristics of the various phenotypes. Let's talk specifically about the metabolic characteristics of PCOS, because this is particularly relevant, not just for how we think about potential dietary intervention, but also the intimate relationship, as I said, between the primary metabolic characteristic of insulin resistance or elevated insulin and androgens, and the relationship that has with reproductive characteristics. So there will be overlap between these two sections. But perhaps the most defining characteristic of PCOS is insulin resistance and glucose intolerance. And this is a study from 1989 that demonstrated this. So what you're seeing with this bar chart here is, so OB-PCOS is women with PCOS and obesity, and then OB-NL is women without PCOS, but also with obesity. And then over here, NOB-PCO is women with PCOS that are within the normal BMI range. And here was women without PCOS that were also in the normal BMI range. And we can basically see this decrease right across. And this measure here is glucose disposal. So how well is the body taking up glucose as a reflection of insulin sensitivity and the ability to actually dispose of glucose? And so this is a non-PCOS normal weight individual with a very high rate of glucose uptake, which would be expected. But even without differences in weight, these two categories here are the same weight. The women in this category with PCOS have quite profoundly decreased glucose uptake compared to their weight-matched non-PCOS counterparts in these open bars here. And then if we go down and we look within the category of obesity, again, there's an effect of PCOS. So the insulin resistance in PCOS is influenced by the degree of adiposity, by the degree of body fat, but it's not dependent on that. And even in the absence of overweight or obesity, women with PCOS will exhibit increased insulin resistance and diminished glucose tolerance compared to weight and age matched non-PCOS women. So this is probably the defining metabolic characteristic of PCOS. And this is just identifying using the most advanced method of assessing insulin resistance, identifying just how prevalent insulin resistance is. And we can see there's effects according to different BMI and effects according to age. So even in individuals with a BMI of 22, which is well within the normal BMI category, so characterized here as lean, women with PCOS have 20% less insulin sensitivity compared to non-PCOS women at the same BMI. And then if we go up to a BMI of 32, which is in class 1 obesity or within the overweight category, that's 30% lower. So there is an effective body weight, but there's also an independent effect simply of the condition, of the underlying condition. And this is summarized here even in the difference between women with PCOS now, comparing overweight to lean PCOS, where overweight PCOS women would have 13% lower insulin sensitivity. So there is an effect of PCOS itself on insulin sensitivity and glucose tolerance. And even in the absence of any higher body weight, there will be evidence of greater insulin resistance compared to weight-matched controls. But as body weight climbs, the effect on insulin resistance will be exacerbated by that. However, and this is probably, if you could come away with one thing tonight, the potentially most important as it relates not just to this insulin paradox in relation to insulin itself, this also relates to the relationship with reproductive characteristics and reproductive dysfunction. So we have insulin over here. We've got this dashed line that you can see coming up here, kind of to this inhibited arrow. What this is illustrating, and then with this line from LH, is that there are both direct and indirect effects of insulin. And there is this paradox of insulin resistance peripherally in, for example, skeletal muscle, and then insulin sensitivity in the ovaries. So how is insulin affecting this overall process? The indirect effect is that insulin influences androgens, which then influences ovarian function. This is represented by this dashed line here. The reason that it's doing this as an indirect effect is because typically when LH levels are high, the ovaries would become resistant to that signaling. They recognize that they're being bombarded with LH and they downregulate their receptiveness to that. So typically this would feed back, as a lot of hormonal systems do in terms of a feedback loop, that would essentially protect the ovaries from the overstimulating effects of luteinizing hormone. Insulin acts, represented by this dashed line here, to counteract that desensitizing of the ovaries to elevated LH levels. So it potentiates the action of luteinizing hormone on the ovaries, on ovarian androgen production. And then we have the direct effect, which is represented by this solid red line here directly from this insulin box over to the ovaries. And this is something that we have more evidence for recently. And this is insulin directly acting on ovarian cells to produce androgens. This is because insulin can directly stimulate ovarian androgen production. We know that now, and I'll discuss some of that evidence. And the fascinating thing is that this may occur even without elevated insulin. You don't need to have hyperinsulinemia. And a big focus in PCOS is, these elevated insulin levels. This doesn't actually need to be present for insulin to have a stimulating effect on ovarian androgen production. And this could explain why, for example, you see in the lean PCOS phenotype, elevated androgens in individuals with PCOS, but that do have normal insulin sensitivity. So I want to elaborate on why exactly this is happening. And in doing so, I'm kind of giving the game away in relation to a latter part of the presentation, in relation to the use of inositols to supplement for PCOS. So you're already going to know what the outcome of is in relation to inositols, but there's a very specific reason why inositol supplementation is so effective in women with PCOS. This was a study back in 2014, a landmark paper that was published that compared women without PCOS to women with PCOS. They were matched for age and weight and all of these other variables. And what this is on the left-hand side of this graph, so we've got two figures here. On the left-hand side, this is the activity of this enzyme known as a paramase. A paramase is an enzyme that converts myo-inositol into D-chiroinositol. Although we typically think of them as supplements, myo and D-chiro are part of an overall family. There's about 9 compounds known as inositols. Inositols were actually once considered to be B vitamins, but they lack some of the criteria to be considered vitamins. They are present physiologically in the body in different proportions in different tissues, and they exert particularly important functions in relation to insulin and also in relation to balancing sex steroid hormone production. In the ovaries in particular, this is important. And the balance is particularly important because under the influence of insulin, myo-inositol is converted into D-chiroinositol through this enzyme, the paramase enzyme. But this conversion is an irreversible process. And what this means then is that the delicate balance of myo to D-chiroinositol that is present, particularly in the ovary and in follicular fluid and ovarian cells, is offset. And this has consequences then for some of the metabolic and reproductive characteristics of PCOS. And you could see here the difference. This is the average up here. So the activity of this enzyme in women with PCOS is significantly higher. And this means that women with PCOS are converting more myo into D-chiroinositol, and this is upsetting the balance that is tightly regulated. And then what you can see here is the myo to D-chiroinositol ratio, but there's a better illustration of this in the next slide that I'll show you. So this study characterized that there's actually an abnormal ovarian response to insulin that alters the very tightly regulated ratio of myo to D-chiroinositol within the ovary. And the reason this is important is because it's in specific ovarian cells known as theca cells that are responsible for androgen production. And D-chiroinositol exerts most of the actions of myo and D-chiro are beneficial, but the balance is important. And one of the functions of D-chiroinositol is to help in the regulation of follicle stimulating hormone and its expression of the aromatase enzyme that converts androgens into estrogens. So that's a positive. That's typically what we would want to see occur. And when this balance is offset, that process is negatively affected, which then contributes to this overproduction of androgens in the ovaries. So overall, the activity of the enzyme 3 times higher in women with PCOS. So they're converting more of this myo to D-chiroinositol, and the ratio 4 times lower. And that represents lower myo-inositol relative to D-chiro. And that's really well illustrated by this study that also came out same year that looked specifically at the ratios in follicular fluid. So these are non-PCOS women, and you can see essentially in follicular fluid, myo-inositol, represented by the light gray, constitutes about 99, 98% of the inositols present in that tissue. D-chiro only constitutes about 1%. You could barely see it up here, represented by the black. Now look at women with PCOS. This is a much more, I think, striking and sharp characterization of this difference. Proportionately now, the level of D-chiro in women with PCOS is significantly greater in follicular fluid. And so this is directly influencing androgen production in these theca cells. And what this study was also demonstrating was that those cells that produce androgens retain their insulin sensitivity, and so continued this process of converting myo into D-chiroinositol. So this is what we mean by this paradox. The ovaries maintain sensitivity to insulin even without overt excesses of insulin. But this can occur while peripheral tissues like skeletal muscle are insulin resistance and glucose uptake is impaired. And this is crucial to understanding the relationship between the metabolic and reproductive characteristics in PCOS. Okay, some other metabolic characteristics because they're relevant. On average, 17 milligrams higher triglycerides, and also around a 14 milligram higher non-HDL cholesterol. So this is both LDL cholesterol and other atherogenic lipoproteins. And both of these might go some way to explaining the fact that there is higher cardiovascular disease risk in women with PCOS. So these are also important when we consider from a nutritional perspective, we can intervene to lower cholesterol, to lower triglycerides. And then the final aspect of the metabolic characteristics that I want to bring to everyone's attention is this concept of an androgen dominant metabolic profile. We know that there are sex dimorphic differences between male and female physiology that relate to metabolic disease risk. And typically this relates to adipose tissue distribution. So under the influence of androgens, men will typically store more visceral adiposity. So that's central adiposity, that's elevated waist circumference, potentially fatty liver. And typically under the influence of estrogens, women will preferentially distribute towards the gluteal femoral region. These are actually protective depots. These increase the storage of circulating fatty acids and reduce triglycerides and improve blood lipids, lower cholesterol. That area of body fat maintains insulin sensitivity. And we know that these differences are influenced by sex hormones because it's not just exclusively divided between men and women, for example. So we know from research in PCOS that this is a characteristic that influences central adiposity distribution in women with PCOS. And we can also see the same in some studies that have used transgender men and women, where you see the use of hormone replacement therapy can influence characteristics of body fat distribution and indeed potentially related metabolic risk. So the whole point is that the primary influence appears to be sex steroid hormones, ultimately influencing, and this is a real oversimplification, but it's a helpful heuristic, what we would call the apple and pear phenotypes. The distribution of central adiposity is typically androgen mediated, and the distribution of the pear to the kind of lower subcutaneous fat areas around the hips and thighs or gluteal femoral regions is estrogen mediated. And this is, again, another example of how we can kind of characterize these differences. Is postmenopausally, with the loss of ovarian estrogen production, there's often a shift postmenopausally to more central distribution, which again indicates the importance of estrogens in defining these kind of apple and pear phenotypes. Why is this relevant for PCOS? Because it's influencing the distribution of body fat and related functions. So the pear shape, typically, again, lower body subcutaneous adipose tissue, and this is generally associated with positive metabolic effects. Under the influence of androgens, there's a preferential shift to central adipose tissue distribution. This adipose tissue depot, and when fat in the liver increases, is also associated then with increased inflammatory markers, increased insulin resistance, increased visceral fat. So this is an androgen-dominant metabolic profile, and part of the consequence is really adverse effects on triglycerides, LDL cholesterol, and blood lipids. And this is, again, particularly relevant because women with PCOS exhibit nearly twofold higher odds of developing fatty liver disease. And this risk is independent of BMI, but it's not independent of androgens. And this was demonstrated in this study. So we've got two graphs here. On the left is fatty liver risk based on androgen levels, and on the right is fatty and liver risk in individuals without elevated androgens. So on the left, we can see individuals with hyperandrogenism have a over threefold higher risk of fatty liver, whereas without elevated androgens, there's really no significant increase in risk. So it's the androgen elevation that's mediating this shift to this androgen-dominant metabolic phenotype that is characterized by central adiposity that potentially increases deposition of fat in the liver and is related to cardiometabolic risk overall. And these are all factors that we can try to address to a degree with nutritional interventions. The final thing, and I won't touch on this too much because the evidence is a little all over the place, is the role of hunger and appetite in PCOS. There's certainly evidence that it's offset a little. Acute subjective measures of satiety and hunger are typically impaired in women with PCOS before and after weight loss. So this graph here is an example. These dotted lines represent non-PCOS controls, and this is their measures of satiety in response to a meal. The top one is before weight loss, and then the bottom one is after. So even, we would expect this. After a period of 16 weeks, as it was in this study, of dieting, their actual satiety is decreased. But it's not decreased by a huge amount relative to baseline in the non-PCOS women. Whereas in the PCOS women, which we can really see here, at baseline, they had nearly a 3 times lower level of satiety. And after 16 weeks of dieting, that was still nearly twofold lower compared to the non-PCOS controls. So lower levels of subjective appetite. When I said the evidence is a bit scatty, what I mean is, how does that translate into actual free living energy intake? And we don't really have good evidence for how these alterations in appetite hormones, in subjective appetite, may influence, day-to-day energy intake and regulation. But we've also evidence as well that objective measures of energy regulation, ghrelin, the hunger hormone, which elevates kind of in response to feeding and prior to eating, is typically higher. And we know from a lot of research that women with PCOS do have lower levels of this hormone, but we don't, again, really have good evidence that you can really do anything with diet to alter this. And some of the interventions with ghrelin as an outcome haven't really shown much of a difference that would lead us to think that we could consider targeting this in a more deliberate way. But it is something to bear in mind that it is a very common aspect of the overall metabolic characteristics that women with PCOS, particularly subjective measures of hunger and appetite, often have lower levels of satiety. And this could be something that is considered through diet. And in one of the dietary interventions, I'm going to highlight a strategy that was particularly useful in one study in relation to overall appetite regulation. Okay, so that was the metabolic characteristics. If we're taking anything out of that, let's take out of it that crucial role of insulin and that relationship between insulin and androgens, and the fact that the ovaries retain sensitivity to insulin and appear to be able to still have this overproduction of androgens without necessarily overly elevated insulin levels because of that sensitivity to insulin. I want to come back to the reproductive disruption that we see to kind of characterize some of the outcomes. So we were looking at the metabolic characteristics, but I also want to introduce this sex hormone binding globulin. So although we've discussed the ovarian androgen elevations that we see, there is also evidence of adrenal androgen excess. All of that will typically combine to have high levels of total or free testosterone in particular. But sex hormone binding globulin is really crucial in this picture because it does exactly that. It binds to androgens circulating free testosterone, which then helps to reduce the active testosterone available. Increases in sex hormone binding globulin are typically a common outcome measure in some of the interventions, and it is a relevant outcome measure. So again, this is something that we'll pay attention to with some of the dietary interventions and nutritional supplements. But this combination of elevated androgens, decreased protective effect of sex hormone binding globulin, and the overall influence on reproductive dysfunction characterized by oligoanovulation. So again, oligoanovulation characterized by cycles that are over 35 days in duration or less than 8 menstrual cycles in a year, and anovulation characterized as no menstrual cycles within a 6-month period. And then we've got follicular arrest. This is because of this imbalance of luteinizing hormone, this elevation of LH. Follicle stimulating hormone isn't able to actually do its job and stimulate proper follicular maturation. And so you get follicular arrest and then also polycystic ovarian morphology. And then there's also anovulatory infertility, which we'll look at in terms of some of the prevalence of this infertility related to anovulation and how that relates to PCOS. So to link in the ovarian and insulin dysfunction, this was a really important study because it was conducted in lean women, this lean PCOS phenotype that had normal insulin sensitivity. And what it was looking at was how you actually reduce levels of androgens. So here in these graphs, these dotted lines that go across represent the upper range of the cutoff for the reference ranges for these hormonal markers. So top left here, we've got free testosterone, this dotted line. So this is women with PCOS in the open white bars and controls matched for body weight that don't have PCOS in the black bars. So their testosterone levels are less than 1 nanogram per deciliter, which is exactly where you would want them to be for women. And then you can see the PCOS control. So despite the fact that they're lean and have normal insulin sensitivity, they have elevated androgens. And this study experimentally used 2 drugs. One knocks out insulin reduction secretion, and this other, leprolide, this knocks out LH production. So let's have a look at some of the outcomes because this really is instructive. In inhibiting insulin, there was a significant reduction. This is free testosterone. So this is by inhibiting insulin with this drug, you get this drop in testosterone to below. It's still high normal, but it's just underneath this upper limit of the reference range. And then with sex hormone binding globulin, which was above the lower limit of the reference range in women with PCOS, but still lower than the non-PCOS controls, there was a significant increase in that. So that's with targeting insulin, we see the reduction in androgens. But suppressing luteinizing hormone with this drug didn't really have as good an effect. You can see suppressing LH without leaving any or without targeting insulin, it's still, in terms of free testosterone, elevated above the upper range. And with sex hormone binding globulin, it really just didn't change at all. Now, if you actually directly target LH specifically and measure that here, then obviously you get a significant decrease because that's precisely what this drug is designed to do. But you don't get the reduction in LH with insulin inhibition. So this study was crucial because what this is showing us is even in the absence of overt insulin resistance, insulin still contributes to the elevated androgens in women with PCOS. And this is without the complication of, for example, increased adiposity or central adiposity. And it's in the context of normal insulin sensitivity and without elevated insulin levels. So this still shows that insulin is mediating elevated androgens in that phenotype. And then we have the sources of androgen excess. It's primarily ovarian elevated androgens or hyperandrogenism. 2/3 of cases, what they would call typical functional ovarian hyperandrogenism. And that's driven by increased or elevated LH and produced in by the ovaries. But there is about 1/4 of cases that exhibit adrenal androgen excess. So there is a contribution of the adrenals, and there's potential complicating factor of elevated adiposity, which increases the conversion of testosterone in adipose tissue. But overall, it appears that the primary driver in PCOS of the elevated androgens, of the androgen excess, is at the level of the ovary. And then we introduce sex hormone binding globulin. This is really important because it relates to insulin resistance. If you look at within this orange rectangle, the clustering of all these data points, this is a measure called HOMA-IR. It's a measure of insulin resistance. And as sex hormone binding globulin levels are lower, now we can see that insulin resistance by this measure is increasing. So this is important as well, and likely explained by the role of SHBG in lowering androgens, therefore improving the overall relationship between insulin resistance and androgens in PCOS. Hirsutism is the primary clinical sign of hyperandrogenism. It's defined as the presence of excess terminal hairs in a male-like pattern. And in terms of prevalence, on average, around 13% of women with PCOS in a range of 8 to 20. But there are big population differences in the prevalence of this particular marker of clinical hyperandrogenism as well. In terms of the prevalence of polycystic ovarian morphology, it's around 28% of the population, and this is specific to the PCOS population, and between 22 to up to 35%. And then oligoanovulation, on average about 15% with a range of 12 to 18. Again, we can see pretty big differences in some of these studies. So this is one in Australia where the average was 24% in a range of 21 to 27%. And the reason this is particularly important is in relation to anovulatory infertility. So this is the cumulative proportion of women diagnosed with oligoanovulation. And you can see PCOS in the red line and non-PCOS in the black line. So you can see this cumulative proportion over time of oligoanovulation in women with PCOS is just by orders of magnitude greater than non-PCOS controls. This is the same then for a diagnosis of infertility, and then also the same for the proportions, cumulative proportion of women that would potentially be attending IVF treatment. So 80% of women with anovulatory infertility have PCOS. And again, this is a crucial overlap then between the kind of reproductive and metabolic aspects of the phenotype that we would hope to be able to at least contribute to improving through dietary and nutritional supplementation. Two final things just to wrap out the reproductive characteristics, because again, some of these are relevant outcome measures that you'll see in studies looking at PCOS. And this relates to anti-Müllerian hormone. There's a proposal that, and again, this is kind of similar to leptin, where the kind of evidence for the role of AMH in PCOS is suggestive, but isn't as strong as our understanding, for example, of the role of LH. And the proposed interaction is that with elevated levels of AMH, you get decreased levels, you get decreased expression of action of follicle stimulating hormone, ultimately leading to an ovulation. Where AMH may be particularly important is, recall that slide for the phenotypes, is in phenotype D, which is the non-androgenic phenotype that are characterized by oligoanovulation and polycystic ovarian morphology. So potentially elevated AMH has a role to play in that specific phenotype. But again, we're still a way off being a little more certain on the precise role of AMH and indeed whether it's something that could be a deliberate target to reduce through any intervention. Finally, then, insulin resistance and ovulatory cycles. So there is this relationship, just to kind of really reiterate this relationship between insulin and the overall reproductive characteristics. So as we can see here, cycle lengths going over 35 to 45 days, 6 weeks to 3 months, or over 3 months. We could see that the level, and this is again, this HOMA-IR, so typically over 2 is considered insulin resistance, over 2.9 is very insulin resistant. And here we can see that, 2.17, 2.05, 2.31. So this is, a correlation of higher levels of insulin resistance with oligo or anovulatory cycles. The reason all of this, of course, is important is because the risk of pregnancy outcomes or adverse pregnancy outcomes is significantly higher in women with PCOS. So there's a 4 times higher pregnancy-induced hypertension risk, a 4 times higher preeclampsia risk, a 2 times higher preterm delivery risk, and a 2.5 times higher small for gestational age risk. None of this is deterministic. Again, this is just the general population observations. And again, the hope is that by having a better understanding of these metabolic and reproductive characteristics, and potentially where, from a nutrition perspective, we could intervene, we can hopefully avoid or attenuate the risk for some of these outcomes. Okay. So with all of that, I think it's important to really think about what exactly in all of this complex physiology, in all of these complex relationships between insulin and androgens, what is actionable for diet and nutrition? Because it's important that we're measured with the strength of evidence and what we actually can achieve. And of course, diet and nutrition often gets put on a bit of a pedestal relative to other potential interventions. So we need to be clear, if we're thinking about PCOS, if we're advising women with PCOS, what exactly are the outcomes that we're going to aim for? I think we could revisit the phenotypes. And as I said, the idea that we could potentially have these phenotype-specific recommendations, we're a little way off that. So there are some broad characteristics of outcomes that we might want to achieve. One is obviously a reduction in androgens and or an increase in sex hormone binding globulin. And we either want to try and achieve this directly through diet, for example, or indirectly because of this relationship between insulin and androgens. Lowering insulin resistance, lowering insulin levels will contribute to the overall reduction in androgens. And so that's the second kind of key consideration that we can actually try to think about addressing through diet, which is the reduction in insulin levels and resistance. And then where possible, trying to target oligo and ovulation. And for example, inositol supplementation would be a good example here. Although there is some evidence for dietary interventions and ovulatory outcomes, including pregnancy outcomes, which we will now move on to discussing. So I think these are good, overall broad aims of thinking about what exactly is it we're looking to achieve as outcomes. And now let's think about how we might go about achieving that. Dietary interventions are going to specifically be focused on exactly that. We'll look at supplements individually in the next section. So here we're talking about food-based interventions of various kind of setups. A big emphasis is going to be on carbohydrate, as you might have guessed, because of the role of insulin. But it is important to note that there is a particular interaction with adiposity, and this relates to the degree of androgenic and insulinogenic profiles in women with PCOS. So sex hormone binding globulin typically lower, testosterone potentially higher, free androgen index higher, insulin resistance higher. But as we illustrated at the outset, that's not entirely related to body weight or degree of adiposity, and is, of course, also influenced just simply by the underlying pathophysiology of PCOS, such that lean women with PCOS will still exhibit greater levels of insulin resistance and indeed elevated androgens. But this does mean that there is a potential role for weight loss. This was the most recent 2019 synthesis of evidence from dietary interventions in PCOS. And on average, the weight loss was a little just under 1.7 kilograms and a range of just 0.7 up to 2.66. And this was characterizing lifestyle interventions, including diet, exercise, and behavioral interventions, often kind of mixed. And this is a really poor return on investment, generally speaking, even in the context of weight loss research, which is horrendous in terms of the overall actual magnitude of achieved weight loss. The average is about 3 kilos. So this is even below that average. And again, this has led to some suggestions that, is it more difficult to lose weight because of the condition? Again, we don't really have good evidence that that is necessarily the case. But there is evidence of, for example, altered functions of body fat that may relate to greater propensity to store body fat. But in the context of weight loss, my take on this low return on investment is that these interventions are just a bit crap in terms of their design and execution. And no one is going to follow something that is pretty miserable for any degree of time. The reason, though, that there is some potential important is the relationship between weight loss and reduced androgens. This is from the same study. So we can see sex hormone binding globulin here, significant increase, free androgen index, significant decrease, and reduction in clinical hyperandrogenism, so reduction in hirsutism that was evident. So what about carbohydrate content and quality? So there's a lot of research that has looked at varying levels because of the role of insulin, because of the role of glucose intolerance. This was a study that compared a kind of normal standard diet, 55% carbohydrate, 15% protein, 30% fat, to a 40% carbohydrate diet, which was characterized by low GI, low glycemic index carbohydrates, and higher protein, 30% protein, with the same amount of fat. Both diets were hypocaloric weight loss diets, and it was a weight loss intervention. But in the context of relatively similar weight loss, there were some additional benefits to the low glycemic index diet. Testosterone slightly lower, greater than the standard diet, but more so quite significant reductions in DHEA, so adrenal androgens, a bump in sex hormone binding globulin, and quite a significant decrease as well in LDL cholesterol. So a lot of the actual magnitudes of change were similar, which we would expect, but still some suggestion that even in the context of a hypocaloric diet, there may be an additional benefit to modifying at least the type of carbohydrate, if not total carbohydrate content. This was followed up with a couple of really interesting studies by this group at University of Alabama, Birmingham. They did 2 studies. We're going to look at both now in succession. And what they did with this intervention was they realized that the problem with the previous study was it didn't match dietary protein between the 2 groups. And so it had the potential for some of those outcomes to be influenced by the fact that protein intake was higher, and protein exerts benefits on glycemic control, as well as other potential benefits in terms of, appetite regulation. So this matched protein, but as a result then did have different levels of carbohydrate and fat. This is actually going to be important. I'm going to revisit this. Again, weight loss diets, 8 weeks on each diet. So the participants all did both diets. And this was a really well-controlled study. The research team prepared all the food, was provided to participants to consume. So they weren't just being relied on to just eat their own diet day to day. Up top, we've got fasting glucose, top right, fasting insulin. So compared to this standard diet, significant reduction in fasting glucose and insulin. This translated bottom left to quite a significant reduction in insulin resistance and also in testosterone. And so this kind of lower carbohydrate, but it's not really a low carb diet, right? I'm going to make this point. These diets are often termed low carb diets in research. They're more lower carbohydrate, moderate carbohydrate diets. And the total fat content is something that's going to emerge as potentially relevant. So again, well-controlled study, both diets achieving the same roughly amount of weight loss, but suggested that the diet composition is influencing differential outcomes as far as glucose tolerance, insulin sensitivity, and reduction in androgens. Same group followed up, same study design, everything, same diet composition and macronutrients, but this time looking in percentage change of body fat and other measures. Significant decrease in total body fat as a percentage, but in terms of body fat distribution, subcutaneous abdominal adipose tissue, remember this visceral storage, central adiposity that we typically see as a result of androgen-mediated distribution of stored fat, significant reduction in subcutaneous abdominal adipose tissue and intra-abdominal adipose tissue, and as well intramuscular adipose tissue as well. So again, in the context of relatively the same absolute amount of weight loss in just kgs, there's evidence that the dietary composition did preferentially influence the level and the particular site of adipose tissue loss, of decreased fat in the central abdominal region in particular. So this ultimately came together in a few meta-analyses. This is one looking specifically at glycemic index and glycemic load in relation to reproductive and metabolic outcomes. And this is total testosterone. These are a number of trials here synthesized together, and a reduction of 0.21 milligrams or nanograms per deciliter, which would be clinically meaningful given some of the small margins in terms of androgens. And this was evident really only for low glycemic index diets. Not to say glycemic load isn't important, it's just there wasn't enough studies to properly get a signal in the noise. So low glycemic index diets led to reductions in androgens and in improvements in metabolic profile. But again, all of these studies were energy restricted diets. So to what extent can we extrapolate that to effects independent of energy restriction? And unfortunately, based on the current evidence with PCOS, we can't. But I think based on some wider evidence, we can make some inferences that I'll come to at the end of this section. So I said dietary fat was something to keep an eye on, and this is because another meta-analysis looking at some of these outcomes actually stratified according to whether the carbohydrate content was lowered without lowering fat, so high fat, low carb diets, which is how most people would conceive of them, or low fat and low carbohydrate diets. And what was interesting about this analysis is that the greatest benefit suggested by this particular study in terms of both androgenic and metabolic outcomes was where diets consisted of less than 35% fat, but also less than 45% carbohydrate. So it's possibly the combination that's important, and higher total fat intakes, may have some slight influence, but particularly if it's more saturated than unsaturated fats, might have a slight influence on certainly central abdominal fat distribution. We know that saturated fats can do that without over consuming energy. So this is something to bear in mind that it may not just be carbohydrate content and quality that we want to consider, it might also be total fat content of the diet. And then this is a study then that importantly looked at these dietary interventions in women with PCOS, but this was specifically looking at pregnancy outcomes. Now, the effect size suggested here is huge. You can see it here down the bottom, 2.87. Really what this was suggesting was that women that underwent a dietary intervention had a threefold higher probability of a pregnancy compared to controls. Now, a lot of these individual studies, you can see how wide these lines are. They're really communicating a lot of noise. They're not very reliable studies. But the three studies circled in or encapsulated in these blue rectangles here were the three studies that had the greatest influence on this overall conclusion, this summary finding. And if you actually look at those individual studies, again, these are studies where carbohydrate intake was in this moderate range, 30 maybe to 40%, and total dietary fat was less than 30% of energy. Now, the other caveat here is all three of these studies were also conducted in a Chinese population. So to what extent can we extrapolate from a Chinese population or an East Asian population and assume that this just applies in any other group? There's always caveats that we have to consider when research is in a specific ethnic group, that we don't necessarily just assume that it applies across the board. Nevertheless, it is something that continually does come through. And those previous studies we looked at with those reductions in visceral fat, for example, they were in a US population. So there does appear to be at least some suggestion that this combination of more moderate carbohydrate intake with lower total fat intake might be actually something. And then obviously, as a result, the energy makeup is being made up with an increase in total protein intake. And this may be an overall macronutrient profile that might benefit in terms of lowering insulin and as a result then improving the androgen profile and potentially then contributing to improved reproductive outcomes. What about another dietary intervention that isn't low carbohydrate, however, is the DASH diet, dietary approaches to stop hypertension. DASH diet typically characterized by very high levels of non-starchy vegetables and fruit consumption, specifically high levels of fruit, whole grains, low-fat dairy, low sodium, low saturated fat diet. This study compared a DASH diet, so higher 52 to 55% carbohydrate, still 16 to 18% protein, 30% fat. Now, the control diet had the exact same macronutrients, so it's just the diet pattern in terms of food composition that differs. Both diets, again, hypocaloric, energy-restricted diets for 12 weeks of an intervention. This is one of the studies that had anti-Müllerian hormone as an outcome, and there was a significant reduction in that only in the DASH diet group and not in the control diet group. Remember, they're consuming the same macronutrient profile, but they're differing in the actual composition of the foods. And then we can see a significant reduction in insulin, quite a large reduction relative to the control, and improvement in HOMA-IR. Remember, this is a point score. So a nearly 1 point reduction when 2.0 or over 2.5 would be insulin resistant is actually quite a meaningful outcome. And an increase in sex hormone binding globulin. This is a little more modest. The point here is that both diets were the same macronutrient profile. So it does suggest an effect of the dietary pattern that was additional to the fact that there was energy restriction. This was then another meta-analysis that actually considered these dietary patterns that have been used in some of this research, DASH diet and low-carb diet. And interestingly, this is this metric HOMA-IR, this measure of insulin resistance. And the reduction in insulin resistance measured by HOMA-IR, 0.91 in the DASH diet and 0.70 in the low-carb diet. Now, these are based on small overall sample sizes, which is quite characteristic of the PCOS research. The low-carb diets contained, again, not low, more moderate at around 40% of energy. And the control group in the DASH diets did contain the same macronutrients. So this is a positive because, again, it suggests that the dietary pattern, the specific food choices, and the lower glycemic index or load of the DASH diets may explain the different effects or the additional benefits. But it's just to highlight that it may not be entirely necessary to have, for example, 40% carbohydrates in order to achieve some of these improvements. And food choice and food selection, food groups are going to be particularly important to determining or influencing some of these metabolic outcomes as well, and then potentially the relationship between metabolic and androgen outcomes. This is what I wanted to touch back on in relation to some potential aspects related to appetite and hunger, and it relates to energy distribution. So previously, we've been looking at, say, DASH diet, macronutrient differences, looking at kind of differences in carbohydrate content and low glycemic index. This was a very different type of study. It was in lean women with PCOS, but the intervention was looking at differences in distribution of energy. So it had two conditions. One consumed 54% of their daily energy at breakfast, 35% at lunch, 11% at dinner. And then the inverse sequence of this. So 11% at breakfast, same amount at lunch, 54% then at dinner. Both diets were at maintenance energies. This is one of the few studies that really is potentially independent of effects of weight loss for 12 weeks. Glucose is up here, baseline, the breakfast group and the dinner group pretty similar. By day 90, this is the breakfast group down here, significant reduction in glucose. And then over here, insulin's the same. It's really pretty similar at baseline. By day 90, front-loading energy in the morning has a significant benefit on insulin levels as well. And this translated to some of the metabolic outcomes, or sorry, the androgenic outcomes. 50% decrease in free testosterone, nearly 105% increase in sex hormone binding globulin, all related to this quite significant 54% decrease in postprandial insulin. And this likely reflected in the percentage of women that were ovulating. At weeks 1 to 4 of the intervention, neither women in the breakfast BF black bars or dinner loaded open bars were characterized, and this is ovulation defined as progesterone levels over 5 nanogram per deciliter. By weeks 5 to 8 in the breakfast group, about 25% have had a return of ovulatory cycles, and by the end of the intervention, just under half of women in the breakfast front-loaded energy group have had a return of ovulatory cycles. So this improvement in the metabolic profile is also evident in the reduction in androgens and the improvement in the reproductive hormone profile. And this does correspond to meaningful improvements in ovulatory rate. And this is something that also impacts positively on appetite regulation. So I think that this could be a useful strategy in the absence of really good evidence that suggests any other way to attenuate the potential effects of lower levels of satiety or higher levels of hunger and appetite that may occur in women with PCOS. Okay. Nutritional supplements. I'm really going to spend most of the time here on inositols. I've included some others just very briefly because they're not really as important. And this is hands down the most important supplemental intervention and nutritional intervention that is available, that doesn't require prescription, and that is as effective as any of the pharmacotherapies available for PCOS. So I think it's important to kind of understand what inositols are doing. As I said, the two most important ones we're focused on, myo and D-chiroinositol. They have different roles. They're both, you can see the pancreas here releasing insulin. This is a cell, and then MI and DCI. So we can see myo-inositol in greater proportions than D-chiroinositol. So MI or myo-inositol is activated by insulin. You can see this arrow here, and it acts to increase the permeability of the cell to glucose. So it's helping, we can see kind of as the microcosm here, to pull glucose into the cell. D-chiroinositol is acting differently. It's acting as what they to essentially have a sensor for intracellular levels of glucose. It's particularly important in regulating glycogen synthesis, so stored carbohydrate. So in tissues that have high levels of glucose storage, like skeletal muscle, the proportion of D-chiroinositol is greater relative to myo-inositol. But in tissues that are really high consumers of glucose, like the brain or the heart or the ovaries, myo-inositol is in much greater proportions. We saw that slide earlier, around 99% of follicular fluid myo-inositol compared to D-chiroinositol. But importantly, under the action of insulin, myo-inositol converts into D-chiroinositol. This is an irreversible reaction, and it means that D-chiroinositol can build up in the cell, potentially having adverse effects on the overall profile. So both of these are useful for improving insulin sensitivity, but they exert opposite roles in ovarian sex steroid hormone actions. When they're in the right balance, this isn't a problem because it's supposed to work. But when D-chiroinositol is present in excess of the tightly regulated physiological balance, this influences, as I said earlier, the relationship between follicle stimulating hormone, the expression of the aromatase enzyme that usually converts androgens into estrogens, and by adversely impacting that process, it contributes in excess to the elevated androgen profile. And we know that women with PCOS, for whatever reason, have lower ovarian levels of myo-inositol relative to higher levels of D-chiroinositol. So that's all the kind of understanding of why these inositols are individually and taken together quite important in the overall pathophysiology of PCOS. There's quite good evidence overall, particularly for nutrition supplements, of their impacts. This was a meta-analysis of myo-inositol in isolation. And this was looking at insulin resistance, significant reduction in insulin resistance, and again with testosterone. And this is at a dose of 4 grams a day. And it really, when you look at the outcome data for myo-inositol or collectively, it's addressing almost the spectrum of these characteristics of PCOS that we've been discussing. It improves insulin sensitivity. It restores ovulatory cycles, improves the quality of ovarian cells and eggs, reduces androgenism, and that's obviously mediated by its positive impacts on insulin levels and on improving insulin resistance. There's some pretty impressive outcome data as well in relation to, and this was myo-inositol alone, again, the same 4 gram a day dose, 25 women that were attending an IVF clinic for 14 to 16 months, all with PCOS, given 4 grams a day of myo-inositol and 200 micrograms of folic acid. On average, ovulatory cycles returned in around 34 days after initiation of myo-inositol supplementation. But particularly spectacular were the numbers, and it is a very small study, right? 25 is not a lot, yet 88% of that, 22 out of 25, having restoration of a menstrual cycle, 72% having continued. It wasn't just a one-off return of ovulation, it was a continued regularization on monthly ovulation thereafter. And out of that 25, 10 pregnancies were achieved, constituting, 40% of the women treated. So this is, quite impressive return on investment for a nutritional supplement, relative to most of the evidence for nutrition or dietary supplements is garbage, let's face it. So what about the potential role for the combination? We know that myo-inositol in isolation can be effective. This is some interesting work that was done by this group where they did a dose response study testing out different. We know that myo and D-chiroinositol, as we've discussed, have different ratios in different tissues throughout the body. And from the kind of standpoint of ovarian function, this is particularly tightly regulated. So this study identified that the actual ratio of these inositols in the plasma is about 40-1, and that supplementing with that ratio of combined myo to D-chiroinositol might actually have a better impact. So this is myo top left here, this is insulin, and top right is glucose. So this is myo-inositol alone. This is a control. Myo-inositol alone. So it's still having a benefit on glucose tolerance and insulin. But look at where this is relative to the combination in terms of that reduction. The combined supplement had a more pronounced effect on metabolic measures and indeed hormonal markers in women with PCOS compared to just treatment with myo-inositol alone, although that is, of course, effective. This was followed up then by a study which specifically divided women into 8 different groups. 8 participants, 7 different myo to D-chiro-inositol ratios ranging from 0 to 1, right the way to over here 40 to 1, 80 to 1, 20 to 1. 4 grams of combined myo to D-chiro, but it was in these ratios. And the primary outcome was ovulation. So this is progesterone in nanograms per milliliter. And again, over 5 on average, indicative of ovulatory cycle. So this would be here. So there was an effect of the 20 to 1, but it wasn't that pronounced. There was some effect that was greater than the 20 to 1 and the 80 to 1, but it's clearly the 40 to 1 ratio that had the most pronounced effect on progesterone, getting it up to 12 nanograms per milliliter. So this was quite a significant impact on progesterone levels, which were otherwise impacted, and indicative of a return to ovulation in the combined 40 to 1 physiological ratio supplement group. There was other markers, outcomes in this study, which were relevant as well. Sex hormone binding globulin here, the biggest impact on increasing, and these are large magnitudes of effect of up to 30 nanomole per liter. Largest magnitude of effect on increasing SHBG was with this 40 to 1 physiological ratio. So overall, the return to ovulation, and again, we need some better outcome data for the combined therapy in terms of, for example, some of the actual pregnancy outcomes. But overall, there is a suggestion that while myo-inositol is effective, and if that's all someone can get their hands on, great, take it. But potentially the combination might be more efficacious for the overall kind of global composite characteristics that we're trying to address through inositol supplementation. Okay, whistle-stop tour then. N-acetylcysteine, some suggestion that it's beneficial for fertility-related outcomes. There's really not good evidence of that. This study did show that it kind of gave a bump to follicle-stimulating hormone and did reduce testosterone. There was an increase in endometrial thickness, but that was based on a small number of studies. And there's little evidence for benefits to ovulatory markers like progesterone. So while N-acetylcysteine has some attraction, it's not really something that you would be hanging your hat on for a potential benefit. For omega-3 fatty acids, there is, though, and it's not necessarily specific to PCOS, but it's specific to the adverse blood lipids we observe in PCOS. It's well established that omega-3 fatty acids reduce triglycerides, and that's no different in PCOS, an average of 10 milligram reduction in triglyceride and nearly 13 milligram reduction in total cholesterol and 10 milligram reduction in LDL cholesterol. The source, whether it's plant-based or long-chain marine omega-3, doesn't matter, but the duration of supplementation does appear to in women with PCOS, so it would want to be taken for over 8 weeks duration. And this is, again, a good evidence-based recommendation to improve blood lipid profiles in PCOS. It's a well-established benefit of omega-3 fatty acids. Flaxseed, some suggestive evidence, very small number of trials. Flax lignans are proposed to have an impact on, for example, sex hormone binding globulin, and omega-3s in flax may also benefit, as we know. This was a study looked at 30 grams a day brown milled flaxseed consumed for 12 weeks. And what was interesting, menstrual status at the start, regular menstrual status in only 38% of participants in the flaxseed group. And by the end of the study, this had increased to 81%. So this evidence for benefit is there, but it's really not robust. It's confined to a handful of small trials. It's kind of one of those things where you might say it can't hurt to sprinkle some flax on the porridge in the morning, but you would not be deliberately putting someone's hopes that there is going to be a specific outcome achieved with this, because we really just don't have the evidence to concretely say that. Chromium proposed to improve insulin sensitivity and glucose disposal. There's some research of it in type 2 diabetes. And lower levels of chromium, it's an essential trace element, have been observed in women with PCOS and insulin resistance. And while this meta-analysis did demonstrate a reduction in insulin resistance, it also demonstrated an increase in testosterone. So that's chromium out because the increase in testosterone and androgens outweighs any potential benefit to insulin resistance. It's a trade-off that is not worth taking, particularly given the role of androgens in PCOS. And finally, berberine, something that, again, in research in type 2 diabetes, there was a lot of excitement for, an insulin sensitizing agent and glucose disposing agent, Planck compound. But really, in terms of PCOS specifically, the evidence primarily suggests that it's the benefit of berberine when it's added to metformin in lowering insulin resistance. And the current evidence that we have for just using berberine as an isolated therapy is not particularly strong. And because inositol kind of does the same things, there's really just no point in going with a really unproven supplement in berberine when inositol is available. Okay, strength of evidence and summary. In terms of dietary interventions, I think this is really what we could suggest: higher dietary protein intake, moderate carbohydrate intake of maybe 30 to 40 grams, but not necessarily, because DASH dietary patterns may also be useful and they typically have a higher carbohydrate intake. But I do lean towards this evidence that maybe something on the more moderate, even 40-45% range with low glycemic carbohydrates might be useful. And then the potential for front-loading total daily energy intake and considering someone's energy distribution over the course of the day, also relevant for glucose tolerance because it's diminished later in the day. So it doesn't really make sense in relation to glucose tolerance, insulin secretion and sensitivity, and androgens to be piling energy intake in later in the day. And I do think there's potential merit for lower total fat intake, where that fat intake is predominantly derived from unsaturated fatty acids. As far as supplements, we could conceive of different approaches in thinking whether we're looking at androgenic outcomes, metabolic outcomes, or ovulatory outcomes. They're obviously related. Myo to D-chiroinositol in the 40-to-1 ratio would be preferred for androgenic outcomes. If myo-inositol itself is available, that's fine. The evidence is nearly just as good. N-acetylcysteine, not really that much of a justification, so it's in a distant third here. Metabolic outcomes, because of myo-inositol's specific roles in insulin sensitivity, that could in isolation be considered if metabolic outcomes were really the primary focus. Omega-3 fatty acids to reduce blood lipids and improve blood lipids. Berberine, really distant third, probably not worth trying. And then for ovulatory outcomes, this physiological ratio 40-to-1 myo to D-chiroinositol, potentially myo-inositol in isolation if needed. It does appear to produce beneficial outcomes, and the evidence really is just as good. So it's more a case of what can be what can someone get their hands on. And again, flaxseed, suggestive but distant third, wouldn't be specifically recommending it for these outcomes. So PCOS is a female reproductive disorder that's multifactorial in nature, encompassing neuroendocrine, ovarian, and metabolic dysfunctions. The exact origins do remain unclear. The Rotterdam criteria encompasses 4 phenotype presentations, which we've discussed, but phenotypes with hyperandrogenism as a feature are typically characterized by higher body weight, insulin resistance, and central adiposity. Phenotypes without elevated androgens do often have normal insulin sensitivity and a metabolic profile similar to women without PCOS, but often have oligoanovulation and polycystic ovarian morphology. When body weight is matched to women without PCOS, women with PCOS also display higher triglycerides, lower HDL, and higher LDL. And this pattern of dyslipidemia is exacerbated by central adiposity in women with PCOS. Elevated insulin drives androgen levels with potential consequences for ovarian dysfunction, menstrual irregularities, and fertility issues. But overt elevated insulin is not necessarily required for insulin to exert effects on the ovaries, because the ovaries retain sensitivity to insulin, even in the context of peripheral insulin resistance. Interventions for targeting risk factors and underlying metabolic physiology include both dietary and nutritional supplements and pharmacological treatments. The majority of evidence for dietary interventions are based on hypocaloric diets, which makes any independent effective diet difficult to determine. Higher protein intake, together with low glycemic load, may reduce body weight and androgen levels while increasing insulin sensitivity to a greater degree than control diets. Where additional benefit beyond the effects of energy restriction alone may be evident is in relation to carbohydrate content and quality. And interventions using moderate carb diets with an emphasis on low GI or GL foods appear to be preferable than higher carbohydrate intake, although DASH dietary patterns may also be beneficial. And this greatest magnitude of benefit may be where total fat intake is lower. Certain individual nutrients are promising for therapy, and inositol should be considered a frontline nutritional supplementation for women with PCOS. Myo-inositol can be used on its own, but the potential physiological ratio may be important for the broad spectrum of outcomes. Established benefits of omega-3, so they should be considered as well for cardiovascular risk factors. And I don't think there's any real merit to other dietary supplements, although for food-based ones like flaxseed, there's no real harm to just, adding it to the daily dietary mix without placing any promise of increased odds of ovulatory cycles or otherwise. Appropriate medical advice should also be sought to consider the use of beneficial pharmacotherapy for PCOS, including metformin and clomiphene. But of course, as nutrition professionals, that is outside our scope. So, as always, I leave you with my nihilistic penguin spirit animal.